Seminar, shoulder pain injuries, specific exercise prescription. And as I said, it's really aimed to give you an idea of some of the general things that you will encounter, some of the most common types of shoulder problems, and to make your exercise prescription a little bit more specific. So in terms of the actual specific learning objectives for the day, obviously better knowledge of anatomy. Who's studied their anatomy recently or even before they came? No? All right, so hopefully that'll be a bit of a good refresher for everyone. Look, knowledge of the common sources of neck and shoulder pain will be crucial. Awareness of some of the common shoulder surgeries that you will encounter. All right, I do a lot of post-op shoulder rehab for different age groups and different types. So we'll go through the 3 most common types of shoulder surgery and also the ability to prescribe more specific exercises as well. There's going to be quite a bit of theory to start off with, quite a bit of prac as we go through. If you have any questions as we go along, or if I say something too fast, you don't understand it, make sure you stop straight away and let me know. Just stick up your hand and we'll hopefully be able to answer your questions. Anything we don't cover, we should have an extra 10 minutes at the end if you want us to cover something that perhaps you've heard of that we don't actually cover in the seminar. And we'll have a look at an interesting case study of a client of mine who was referred by a trainer at the end too. So the competencies, look, this is really referring to the test at the end. So this is the stuff you need to try and take in because this relates to the exam. Those of you who are collecting Fitness Australia CEC points, then we do have a little multiple choice question at the end. So just to have a bit of an idea of those things on the screen. As always, I start off with a standard warning that with your level of training, obviously you're not trained to diagnose problems, to diagnose pathology. So if your client comes to you and says, look, I've got shoulder in this part, and you're pretty keen after the courses, you think, right, I think that sounds like impingement. Look, just be a bit careful in the way that you talk to your clients. You know, you guys are qualified to look at postural muscle imbalances. You're qualified to test muscles and prescribe corrective exercises, but not to make a formal diagnosis as such. All right, and that's the crucial thing. You don't want to get yourself into trouble as far as litigation goes. Okay, so bony anatomy first, all right? So obviously the shoulder joint is made up of the scapula, okay? We have the shallow glenoid fossa here, all right, which articulates with our long arm bone, the humerus. The main thing to pick up when we're looking at the actual glenohumeral joint proper is that you have a very rounded ball, okay, with a very shallow socket. Okay, it's quite flat. It's not like the hip joint, which is a nice congruous ball and socket. It's a very shallow socket, the glenoid. So what that means is that we have an extraordinary range of movement. It's the most mobile joint in the body. It can go in all sorts of different directions, but as a result, it's also the most unstable joint in the body as well. Okay, so what we sacrifice for stability, we gain in mobility and vice versa. You know, and you've all heard of people with shoulder dislocations, of course. The shoulder is the most commonly dislocated joint, perhaps maybe except for the fingers in the footy players. The other joint that's definitely relevant to the shoulder joint is the AC joint, which is the joint between the clavicle and the acromion process, which projects forward from the spine of the scapula here. So you can feel the AC joint really easy. It's that sort of bump on top. If you find your clavicle there, run your fingers out, okay, and actually find where there's a little bit of a dip, there's a little bit of a gap between the end of the clavicle and the front of the acromion. That's your AC joint, okay? And that's, we'll cover some of those injuries today as well. And then obviously we have some of the coracoid-clavicular ligaments that stabilise the AC joint. When we look at the shoulder anatomy from side on, so we've obviously taken the head of the humerus away, we're looking into the glenoid cavity here. The very shallow labrum, okay, it is actually increased by this cartilaginous rim called the glenoid labrum. So this sort of structured bit of cartilage around the outside of the glenoid does actually deepen the glenoid to create almost like a little bit of a suction. It works almost like an atmospheric pressure where it sort of starts to curl around and kind of helps to hold or suck the head of the humerus into the glenoid. So that improves some of our stability there as well. You can see the long head of biceps tendon, which actually inserts into the top of the labrum. And then surrounding the labrum, we actually have our joint capsule, all right, which we'll look at on another slide in a minute.